Okay.
شكرا.
Yalla. If you recall, last week we started speaking on metabolic bone diseases, but we did not finish. We reached the section where we were going to discuss osteoporosis. I would like to mention something. كل اللي عم بحكي لكم اياه اخذوا من الاورثو بولتس، اخذوا من الريفيو كورس تبع الامريكان اكاديمي، اخذوا من عدة كتب يلي بتدرسوا منهم كل يوم، بتلاقوا في اسم منهم نسخات بكاملها منها. My job is to explain everything, but you should read. If you don't read, you will not gain any knowledge. هلا إذا بتطلعوا بالأوستيوبروسيس، شو يلي بيعمل أوستيوبروسيس؟ What causes it? Immobilization. حدا قاعد بالتخت ما عم بيهز، أو عنده cast. It will become a localized form of osteoporosis. أو إذا عنده paraplegia كمان بيصير عنده osteoporosis. كمان بتلاقوا هولي اللي بيطلعوا على القمر they have osteoporosis لأن في no mechanical stimulus for bone mass formation. كمان you'll find that you can have it as a deficiency in diet. Patients on heparin or methotrexate treatment or on glucocorticoids end up having osteoporosis if they're on a chronic treatment form. It can be idiopathic. مثلا بتيجي بالشباب او بالبنات ما بين 10 و 18 سنه غير ما يكون عندهم انوركسيا منوريه او نيرفوسا، بيجيهم لسبب ما بنعرف شو هو، بصير عندهم اوستيوبروسيس، بتقعد معهم على كم سنه وبعدين بتصح منها لحالها. في a form of osteoporosis which is very similar to osteogenesis imperfecta type 1. بس الفرق بين الاثنين انه ما في blue sclera. بالاوستيوجينيسيس imperfecta في blue sclera. Patients on the rheumatoid treatment, they also have osteoporosis. Patients who have sarcoidosis or any condition which is causing liver disease, they have cirrhosis, they can have osteoporosis or would have osteoporosis. Patients with renal tubular acidosis, neoplasms such as myeloma, leukemia, lymphoma, killer patients, they present with increased bone density and osteoporosis because the quantity of bone matrix is less. Okay. Also, patients who have adrenal cortical hypersecretion and patients who have ending up with glucocorticoid excess also. Another problem women have when they have menopause, they have less estrogen. Therefore, there is nothing to block the destruction of bone by the osteoclast. So you have destruction of bone. In normal women, you will have a loss of 0.3 to 0.5% of bone per year. But there are some other women who really lose much more. And these are the people who end up with severe osteoporotic findings. They become shorter, they bend forward, they have a hump. And men after a certain age of around 70, they develop a certain degree of osteoporosis. Now, osteoporosis is a general term indicating a symptomatic generalized decrease in bone mass. The quantity of bone is less. When you have a quantity of bone matrix which is less, it can accept a less amount of minerals like calcium and phosphate. Therefore, the density of bone is less. There are three varieties. One is primaries, the other is secondary, and the last is idiopathic. Let's speak about primary osteoporosis in bone mass due to aging, often resulting in painful fractures and deformities. كل يلي على الامرجنسي rooms بيقشعوا patients coming with severe acute back pain, and these patients could have microfractures due to osteoporosis. And for this reason, we treat some of them who have severe pain with augmentation, with bone cement, and this helps them relieving of the pain. So you have to keep this in mind. So primary osteoporosis may be subdivided into senile and postmenopausal varieties. Now let's discuss senile. Senile osteoporosis is the gradual, I repeat, the gradual loss of bone mass that begins in middle adulthood and proceeds relentlessly until death. This gradual reduction in bone mass occurs in both men and women, but of course in women more. And there are certain ethnic groups who are more than others, and cultures, so it varies. You have postmenopausal osteoporosis. This is a rapid bone loss, which is engrafted on the process of senile osteoporosis. This form of osteoporosis is experienced by women whose bones are extremely, I repeat, it is experienced by women whose bones are extremely sensitive to estrogen withdrawal. When you withdraw the estrogen, لما بتبطل في estrogen ما في حدا يجي يدافع عن العظم بقى against the osteoclast. تيجي الاوستيوكلاست and it starts destroying bone by its function in Hoship's lacunae, and as a result you have a decreased density of bone. These women suffer a rapid reduction in bone mass in the years following menopause. Secondary osteoporosis is premature bone loss or an exaggerated age-related bone loss caused by a wide variety of endogenous or exogenous factors not related to age. These factors include corticosteroid therapy, diabetes. We know that a large number of patients who have diabetes have osteoporosis, or secondary amenorrhea, which occurs in anorexia nervosa, for instance, or all these young women who are sporty-ish, where for some reason or another they develop amenorrhea and they have a very poor appetite and poor nutrition. Identification and the removal of these deleterious factors slows the rate of bone loss and often restores bone mass. On rare occasions, young adults or even children become osteoporotic in the absence of an identifiable endocrine abnormality or risk factor. This clinical syndrome is called idiopathic osteoporosis. A bit about skeletal failure. In any of these syndromes of osteoporosis, the loss of bone mass may become so severe that the structural function of the skeleton is lost. It's no longer able to support the organs and tissues that surround it. Fractures occur spontaneously or with only the slightest trauma. If you recall, كلكم يلي عاملين التدريب بيجيكم واحد مكسور وركه, and that patient tells you, I didn't feel that, I didn't fall. I felt that my hip fractured and then I fell. This you hear it quite often. On simple low energy trauma, they end up having fractures. As a result, patients live with constant pain and disability. Why? Because they have microfractures, and every time they have microfractures, they have pain. They have to live with it. This condition is known as skeletal failure and is a concept akin to renal failure or heart failure. When we say skeletal failure, when we say renal failure, when we say heart failure, they're all terms to represent the condition of the organ which is involved. In skeletal failure, the bone is involved. The strength of bone is involved. In renal failure, the kidney is involved, and heart failure likewise. What do we mean by peak bone mass? Peak bone mass is the amount of bone which has been formed by the time the individual stops or reaches a stable level and no longer increases his bone mass. This is what we mean by peak bone mass. It's an important factor determining whether or not a person's skeleton fails in late adulthood is the amount of bone present before the reduction in the bone mass begins. Yani, it is the highest level at which bone has formed before our friend, the osteoclast, begins to absorb or destroy bone. During skeletal growth, the point of maximal bone development is known as peak bone mass. Bone mass measured by DEXA scans is the amount of bone per unit area and is independent of bone size. The amount of bone present at peak bone mass is the starting point from which bone loss begins. And it is the maximum amount of bone formed before there is an arrest of bone formation, and finally destruction sets in. Bone mass increases dramatically throughout puberty, and in girls plateaus about 2 years after menarche. يعني إذا إجت المرأة المعاد ب 13 من بعد سنتين يعني 15 بيصير عندهم البيك bone mass. Girls have a peak bone mass at an earlier level than boys, which is around 17. Boys plateau about the age of 17. At this plateau, about 95% of the bone mass is present. However, additional bone mass accumulates when men and women are in their 20s, even after skeletal growth is complete. Healthy women may gain additional bone even until the age of 29. In summary, people usually reach peak bone mass in their mid to late 20s. This is where the war begins. This is where the fight begins. This is where the osteoclast begins to eat up bone. Many factors govern the amount of bone present at the time of peak bone mass. About 80% of the variance in peak bone mass is due to genetic factors. Let's go into the African American woman. Generally, they reach a higher peak bone mass than Caucasian women. من هيك اللي بنقشع osteoporosis less in African American women than Caucasians. By contrast, Asians and Hispanics have a lower peak bone mass than the Caucasians. So it varies among cultures, the amount of osteoporosis. In addition to environmental factors also play an important part. What are the environmental factors? These contribute to peak bone mass. Among these factors are childhood nutrition. How well do you feed your child? This is particularly important. And for example, if you have a low calcium intake during adolescence, this is associated definitely with a lower peak bone mass. Although the recommended daily calcium intake for adolescents and young adults is 1,200 milligrams, one survey discovered that only 15% of girls, 15% of girls and 53% of boys met this requirement of taking 1,200 milligrams per day. We don't follow the rules. We don't follow what is important. And that's why the net bone mass is less than the usual. Protein consumption is important. Malnourished children in some low socioeconomic groups are likely to have lower peak bone mass and as a result are more likely to have weak bones in old age. You want your children to be strong, feed them well, follow the rules, give them the necessary nutrients, and you'll find that they will have a happy ending. Malnutrition is not unique to low socioeconomic groups. However, in affluent populations, adolescents obsessed with the desire to be slender, to be sexy, to be attracted to men, are also probably malnourished because they don't ingest the required amount of food, the necessary amount of food. They always want to be thin. Ballet dancers, people who are jumping on the trapeze, also you see that they are thinner than normal, especially at risk of malnutrition and therefore of low peak bone mass are those training for a sport or a career requiring a thin body. Young fashion models, واحدة بدها تصير modelist, she is thinner than normal, but she cuts the food from her mouth, from her body. Gymnasts, ballerinas, and figure skaters. Acquiring maximum peak bone mass in the first 3 decades, يعني أول 30 سنة مهمة الواحد to acquire the necessary bone mass of life is the initial step in preventing primary osteoporosis. The quote, and senile osteoporosis is a pediatric disease. It emphasizes the importance of this concept of proper nutrition. Primary osteoporosis. Primary osteoporosis is a major public health problem because it causes pain and disability in many people, and because it costs so much. It is a common disease. Osteoporosis, I've taken this, I think was taken copy from OrthoBullets or the American Academy Review course, stating that osteoporosis affects more than 26 million women and leads to 1.5 million fractures each year. It fills your pockets with money, orthopedists. 54% of postmenopausal women are osteopenic. Another 30% are osteoporotic. Imagine how much. Imagine. 54% of women at the age of 50 will sustain at least one osteoporotic fracture during the remainder of their lifetime. انتبهوا, 54% after the age of 50 would have one insufficiency fracture occurring as a result of osteoporosis. 27% of women have sustained a vertebral compression fracture by the age of 65. An estimated 300,000 hip fractures occur in the United States each year. 90% of these occur in people from 70 to 90, and most are due to osteoporosis. The fatality rate after hip fracture, we know that in the first year is 24%. Why should we have this? We have to prevent this. And we have to prevent it by treating or preventing the occurrence of osteoporosis. In 1995, the per patient expenditure for a hip fracture averaged $32,000. In 1995, the total estimated expenditures for treating osteoporotic fractures was $13.8 billion in the United States. Hip fractures alone account for $7.1 billion. In the next 10 years, an estimated 5.2 million hip, spine, and forearm fractures will result in medical costs exceeding $45 billion. So يا شباب, so يا ستاتي اللي عم بيسمعونا, لازم تفكروا بالproper nutrition of our children by giving them a proper nutrition to arrive at a sufficient peak bone mass at the end of growth will prevent these from occurring or decrease these from occurring. So we have to keep this in mind. As many as 54% of white postmenopausal women show evidence of decreased bone mass, and another 30% have clinical osteoporosis. Thus, white women alone account for 26 million people who suffer from weak bones in the USA. Osteoporotic bones, we all know, are weak and they fracture easily. Not only are they weak because of decrease in bone mass, they are also brittle because of the changes in the organic matrix. Patients with osteoporosis commonly suffer vertebral compression fractures, hip fractures, and fractures of the distal radius, Colles fractures, or whatsoever you call them. So these are somewhat preventable. These fractures are common in the elderly, not only because their bones are weak, but also because they fall more often. Yani we should not blame all the cause on osteoporosis. Don't forget that these elderly don't hear well, they don't see well, The joints are limited in motion, and therefore anything in their way, they could trip and have a fall. But there is a difference between having high quality bone and poor quality bone. Many people fall and don't have fractures because the bone is strong. So you have to keep this in mind. In addition, you should think that additional causes may be due to cerebrovascular disease. We know that muscle weakness occurs with age, and many of the elderly people take medications. For instance, if you have a patient on epilepsy, he takes sildenafil, and therefore this is known to produce osteoporosis and osteomalacia. So don't forget this. Over a third of institutional patients have a history of a fall. Even without a fall, osteoporotic bone may fracture spontaneously, as I have so repeatedly repeated. An elderly woman may report that she felt her hip snap and then she fell. Likewise, almost half of the vertebral compression fractures occur spontaneously. Vertebral fractures are the most common complication of osteoporosis. More than 25% of all women over 65 of age have sustained a crush fracture. Most commonly, the thoracic or lumbar vertebrae are involved. If you come to me and say, I want to sit for the Arab boards, and you say, I didn't see a fracture of the lumbar or thoracic spine in an osteoporotic woman, then you are not fit to pass your exam. You have to keep this in mind. You have to see them. You have to ask about them. Every elderly patient who comes with back pain, you should think of an osteoporotic microfracture, or of course of metastasis. There are two clinical patterns of vertebral fractures. The first pattern is the acute vertebral crush fracture. Patients present with the acute onset of severe pain and muscle spasm. These are the patients that are brought to you in the emergency room. They're screaming, ouch, ouch, I'm having a lot of back pain. Most of them are elderly. Some either had a fall or some, while lifting something heavy, had this episode. Ya Jama'ah, after a certain age, 50 to 60, if a patient has back pain, it's not the disc like we think of in the younger individuals. You have to do a differential diagnosis and take a proper history and physical exam. Occasionally, an acute osteoporotic compression fracture is very difficult to distinguish clinically and radiologically from metastatic carcinoma. You have to keep this in mind. You have to have a proper differential diagnosis. When we ask you in an exam, give us a differential diagnosis, you should sit and think, what could give you the same picture? What can let you be confused with one condition with respect to another? Keep this in mind. This is an anterior posterior x-ray of the spine. It shows an acute compression fracture, but it's not at one level, it's at multiple levels. So some are acute, some have been for some time. So you need studies to tell the difference. If you have edema and it's recent, then you say this is a recent fracture. If you don't have this on T2, it's not. So you have to be able to tell the difference between an acute and a chronic fracture. This is the whole mount photomicrograph of a spine with an acute vertebral compression fracture. You can see the fracture. You can see how the vertebra is compressed. And you can see that the pedicles are shifting more or less laterally. For this reason, you see that the width of the vertebra on the frontal plane is wider than the one below and above, while it's a crush fracture. It's a burst fracture. Biopsy may be the only way to make the correct diagnosis. The second pattern of vertebral fracture is the asymptomatic anterior wedge fracture. So you have the crush fracture and you have the anterior wedge fracture. Usually, multiple vertebrae are involved, a pattern which causes kyphosis and a gradual reduction in height. So it is the anterior wedge fracture which lets you be hunched or kyphotic, and if you measure your length, you'll see that from months to 2 months to 3 months, the height is varying. Many of them could be asymptomatic. Now, although vertebral fractures are most common complication of low bone mass, hip fractures are associated with the highest mortality. They cause the most financial strain on the health care system. Am I clear? Khalid? يا شباب am I clear؟
دكتور جون
ايه
كل شيء واضح و very clear.
Very clear type. Okay.
Thank you.
Approximately 300,000 hip fractures occur in the United States each year. The mortality rate following hip fracture, we said, is 24%. Most survivors are disabled, many seriously. The staggering annual cost to treat hip fractures in the United States, as I mentioned, exceeds $7 billion. These are taken from 2 different references, confirming of how much is spent on an osteoporotic fracture of the hip. What about the pathogenesis of primary osteoporosis? Similar to all forms of osteoporosis, primary osteoporosis results from an excess of osteoclastic activity over osteoblastic activity. And there is more bone destruction than bone formation. Although this discrepancy in cellular activity is usually not apparent in routine histologic preparations. The bone loss occurs in tiny increments during each remodeling cycle. In the normal skeleton, bone mass is maintained because remodeling is balanced. I repeat, this statement is very important. In the normal skeleton, bone mass is maintained because remodeling is balanced. Yani, the amount of osteoblastic destruction is equivalent to the amount of osteoblastic bone formation. The amount of bone deposited by a team of osteoblasts equals the amount removed by a team of osteoclasts. However, in osteoporosis, osteoblasts deposit a little less than the amount that was removed. With each remodeling cycle, skeletal mass becomes a tiny bit less. Any condition leading to an increased activation of remodeling cycles speeds up the reduction in skeletal mass. The discrepancy in the remodeling cycle begins in the 4th decade At this point, osteoblasts synthesize less bone at each remodeling site, and the skeletal mass begins to very gradually decrease. If you recall, I'm telling you the story of osteoporosis. I'm discussing it in a very simple fashion so that in our exams, I don't want to hear that you don't know about osteoporosis. It's very simple if you grab what I'm telling you. That's the way I remember it, as a story. And it sticks in my brain. And that's what you should do. Now, bone loss occurs at a rate of 0.3% per year in a man and 0.5% per year in a woman. This is in normal individuals. The reason why osteoblasts synthesize less bone, although not fully understood, is likely due to the osteoblast senescence. يعني مثل ما نحن عم نخطير الاوستيوبلاست عم تخطير. Its efficiency is no longer as strong as it was. In addition, they don't live long enough. So if you ask this question, why does this occur? You should say that the osteoblast is weaker, it's not as stronger, it cannot synthesize enough bone, and the duration of life of the osteoblast is not long as it was in the past. The message sent to recruit osteoblasts after the resorption phase of the remodeling cycle also may be deficient. يعني إذا حدا جاي to attack a certain area وفي guardians at some distance, if the message is not strong enough to come and save that area, the people who are coming to save it are weak because they received a weaker message. Therefore, that explains why osteoblasts don't function well. Now, this may occur as a result of decreased synthesis of growth factors, such as transforming growth factor beta or insulin-like growth factor. Finally, decreased stress on bones. We know that stress is a stimulus for bone formation. When we all age older, there is a decreased stress on bones due to the reduced physical activity of older people, probably also contribute to decreased bone synthesis. Hormonal factors are probably active in reducing bone mass in osteoporosis. Parathyroid hormone levels, a response to low serum calcium, are increased in many elderly patients. The lowered serum calcium is due to a combination of several factors: a decreased calcium intake, a decreased calcium absorption. The intestines don't absorb sufficient amount of calcium through the duodenum or passively through the jejunum, or a renal calcium leak. So calcium has an effect. The level of calcium is important. A decreased serum 125 dihydroxy vitamin D2 level noted in some patients with osteoporosis is another possible factor leading to bone loss. Decreased sun exposure or dietary intake, both common problems in the elderly, could be responsible for 125 dihydroxy vitamin D levels. You need sunlight. You need a proper dietary intake. We don't have it. And in many countries who wear, especially in women, who cover the skin of their body, in the majority of their body, have a higher rate of osteoporosis. Also, the renal synthesis of 1,25-dihydroxy vitamin D3 is impaired in some elderly patients. Another possible cause for low serum calcium is the genetically acquired defect in the receptor for vitamin D, which has been demonstrated in some patients. Senile osteoporosis. Primary osteoporosis encompasses two patterns of bone loss. You have the senile type 2 osteoporosis, and you have the postmenopausal type 1 osteoporosis. Senile osteoporosis is the pattern of skeletal loss that naturally occurs with aging. This pattern of bone loss, which begins in the fourth decade and continues throughout life, occurs in men and women in all racial and ethnic groups. The process usually becomes clinically apparent about the age of 70, and patients often present with painless vertebral wedge deformities. Gentlemen, if you notice, I'm giving you several repetitions so that what I'm telling you will be maintained among your brains while studying and lecturing. Senile osteoporosis equally affects the cortical and cancellous bone. Because the volume of cortical bone in the skeleton is greater, senile osteoporosis has its greatest effect on the cortex. So, fellows, if I ask a multiple choice question, one of which an answer would be that in senile osteoporosis, the amount of cortical bone lost is more than that of cancellous bone because of the greater quantity of cortical bone. As a result, patients commonly suffer from fractures of the femoral neck, as we have mentioned, and in area consisting mainly of cortical bone. Asymptomatic vertebral wedge fractures also occur, and because of the increased osteoclastic activity, is not a major factor in this pattern of the bone loss. Senile osteoporosis also is known as low turnover osteoporosis. And you should notice the difference between low turnover osteoporosis and high turnover osteoporosis. Postmenopausal osteoporosis, again. Some women at the time of menopause develop a rapid increase in bone loss. This pattern of postmenopausal osteoporosis, it lasts from 3 to 6 years, and it appears to be self-limited after 6 years. This process primarily affects trabecular bone, where the rate of loss is 3 times normal. Because of their greater proportion of trabecular bone, vertebrae may lose 5% of their mass per year. Women with this syndrome often present with an acute vertebral crush fracture, in contrast to asymptomatic wedge fractures which occur in senile osteoporosis. Distal radius fractures are also common. The biochemical abnormalities underlying postmenopausal osteoporosis are complex. One established factor is that estrogen withdrawal increases osteoclastic activity and therefore bone turnover is increased. Estrogen normally inhibits osteoclastic activity indirectly by inhibiting the interleukins 1 and 6 cytokines known to be potent osteoclast activators. So you have to know that how does estrogen affect the osteoclast? You have to say that it interferes with the action of interleukins, can be 1, 6, 17, etc. Estrogen inhibits the production of interleukin-1 by peripheral blood monocytes. After estrogen withdrawal, interleukin-1 enhances the production of interleukin-6, a powerful osteoclast stimulator. Experimental observation confirms that estrogen withdrawal stimulates osteoclasts. A mouse model oophorectomy increases interleukin-6 activity. Moreover, in this model, antibodies against interleukin-6 prevent any bone loss. The rapidity of bone loss in postmenopausal osteoporosis is due to a high bone turnover. Please write this down, okay? The decreased increment of bone formed in the remodeling cycle, a feature of senile osteoporosis, exaggerated by the high turnover. For this reason, postmenopausal osteoporosis is also known as high turnover osteoporosis. Clinical and radiographic features. The usual patient is tall, thin, fair-haired, Caucasian woman of Northern European descent. She is likely to have lax ligaments. Small Asian women are also prone to develop osteoporosis. By contrast, osteoporosis is uncommon in African Americans and in obese people. Why in obese people? Because there is in the fat dihydrogesterone, which has a function in activating and producing estrogen, which acts against the osteoclast. So you have genetic, the female, the Caucasian, North European descent, the Asian, patients who have fair hair and skin. They are tall, thin body habitus. The behavior is inactivity. Patients smoke a lot because we know that smoking interferes with osteoblastic bone formation. Alcohol abuse acts on the liver and interferes with absorption and all the works. Malnutrition. So all these act together. Obesity protects against osteoporosis for two reasons. Its increased weight stresses the bone, a factor which helps maintain balance remodeling. More importantly, obese women have higher levels of protective serum free estrogen. Free estrogen results from the peripheral conversion of adrenal androgens to estrogen, a conversion which occurs in adipose tissue. In patients with primary osteoporosis, bone loss is insidious and asymptomatic until fractures occur. Vertebral fractures beginning in the 6th decade are the most clinical manifestation. They may be painful or asymptomatic. Atypical clinical fractures of patients with long-standing osteoporosis, dorsal kyphosis, the so-called Dowager's hump. Don't forget this. It's called the Dowager's hump. This kyphosis, a result of successive anterior vertebral wedging, leads to a loss of as much as a foot of the patient's original height. And this shows you they have anterior wedging, and gradually they have a loss in the height from A to C. You see it. The length is much less. And this is the Dowager's hump. In the early phases of primary osteoporosis, changes are not apparent with plain radiographs. The most sensitive imaging modality to detect early osteoporosis is dual energy X-ray absorptiometry, which is the DEXA scan. A collimated X-ray beam is passed through standard bone segments, such as the hip or spine. The amount of absorption is measured by a computer. A T-score, a value compared with all patients, greater than minus 2.5 standard deviations from mental defines osteoporosis. And if it's minus 3, minus 3.7, it's osteoporosis. Then the limit should be minus 2.5. Why? From 1 to minus 2.5 is osteopenia. Although the DEXA scan accurately defines bone density, it does not explain skeletal fragility conditions in patients who do not have low bone density. In these patients, bone quality, not density, must be evaluated. The most important modality for this evaluation is the quantitative CT or micro CT scans. These modulations provide an image of the microarchitecture of bone by studying trabecular architecture and connections. A 30% loss of bone mass is required before osteoporosis is apparent on plain radiographs. By this time, bones have lost 50% of their strength. In the advanced stages of osteoporosis, bones are diffusely osteopenic. Changes are most evident in the spine. Preferential loss of the, you see, you have the vertical trabeculae and you have the horizontal trabeculae. What holds the vertical trabeculae vertical? It's the interconnections that the horizontal trabeculae make. So, preferential loss of horizontal trabeculae makes vertical trabeculae more prominent, but sometimes the vertebral bodies appear empty. This is a lateral chest radiograph in a patient with severe osteoporosis. There is kyphosis secondary to vertebral wedging. A codfish appearance is often present due to collapsed enclaves and bulging of the disc into the vertebral body because the disc becomes stronger bone. So the vertebral body appear as biconcave, and this is what we call codfish vertebra. In the appendicular skeleton, the cortices are markedly thin, and the trabecular pattern is lost. In the femoral neck, the pattern of trabecular bone loss may be used to assess the severity of osteoporosis. With routine histopathologic techniques, only a diminished quantity of bone is present. the trabeculae are thin and disconnected, a feature manifested by free-floating trabeculae in the histologic sections. In some cases, trabecular plates are replaced by thin rods. Look at over here. You see that the trabeculae are floating. You have buttons and small trabeculae. These are detached and floating free. This is a case of severe osteoporosis. And you can see that the trabeculae are thin. And there are small buttons. You see still trabeculae present of trabecular bone. Cortices are also thin, especially the subchondral cortex, adjacent to the large joints. In addition, cortical porosity is increased by enlargement of the Haversian canals and by endosteal erosion. Architectural changes are an important pathologic feature of osteoporosis. These changes are most prominent in the vertebral bodies, where the number of horizontal. Can I take 1 minute free just to speak? Hey George, عم بعطي lecture online لكل الدول. نحن بعدنا موعد الساعة 8. لا. طيب no problem. اوكي خلاص وصل بقى. Architectural changes are an important pathologic feature of osteoporosis. These changes are most prominent in the vertebral bodies where the number of horizontal trabeculae is markedly diminished. Normally, the horizontal trabeculae are crossed bracing struts which support the load-bearing vertical trabeculae. In osteoporosis, unsupported vertical trabeculae result in high prevalence of microfractures within the vertebral body. What I'm stressing is that when the horizontal trabeculae no longer hold the vertical trabeculae, the support remaining for the longness or the lengthening of a vertebral body or the height of a vertebral body no longer exists. So it collapses. Typically 200 to 450 healing or healed trabecular microfractures can be identified in autopsy specimens of osteoporotic women. If the rate of trabecular microfracture exceeds the reparative remodeling process, vertebral collapse occurs. Histomorphometric analysis of undecalcified, I repeat, undecalcified bone of osteoporotic patients has demonstrated low, normal, and high turnover rates. The increased osteoclastic and osteoblastic activity of high turnover osteoporosis is rarely recognized with routine histologic examination. Therefore, histomorphometric studies which accurately identify the rate of turnover may be important in planning therapy and monitoring the results. In addition, histomorphometric studies may demonstrate a component of osteomalacia, a condition very responsive to treatment. Secondary osteoporosis, although most cases of osteoporosis are due to age-related factors, some are caused by identifiable exogenous or endogenous agents. These agents may cause premature skeletal failure, or they may exacerbate the normal rate of bone loss, a condition known as secondary osteoporosis. These are, what are the radiologic studies? Are the DEXA, the bone scan to rule out focal lesions like metastatic lesions. The history to rule out family history of fractures or blue sclerae. Poor dietary habits, previous steroid therapy, previous gastrointestinal therapy, smoking and alcohol abuse, history of bed rest. The laboratory studies, what should we ask for? Routine blood count, electrolytes, calcium, phosphorus, and albumin, alkaline phosphatase, liver enzymes, serum 25-hydroxyvitamin D, 1,25-dihydroxyvitamin D, parathyroid hormone levels, indices of bone turnover, osteocalcin, tartrate, resistant acid, phosphate, urine hydroxyproline, and peridium crosslinks. Radiologic studies are the DEXA, the quantitative computerized tomography, bone scan, and these are the most important. Glucocorticoid excess is the most common cause of secondary osteoporosis. Excess endogenous glucocorticoids are occasionally due to adrenal hyperplasia or neoplasia, and more commonly, excess glucocorticoids are caused by steroid therapy. Patients receiving doses of steroids for diseases such as lupus, chronic lung disease, multiple sclerosis, for post-transplant immunosuppression, commonly develop secondary osteoporosis. As many as 50% of these patients experience bone loss. 30 to 35% of patients on long-term steroids experience vertebral crush fracture, and the risk of hip fracture is increased by 50%. In an individual patient, bone loss, which is almost pronounced in the first 6 months of therapy, may be as high as 40%. Even low doses of steroids cause osteoporosis. Regimens of 8 to 10 milligrams of prednisone are known to cause osteoporosis. So you have to pay attention. Although the degree of bone loss is proportional to the cumulative dose, the effect of steroids on the skeleton is almost immediate. An acute administration of 10 milligrams of prednisone would suppress osteocalcin levels, an index of osteoblast activity, by as much as 80%. Major impairment of bone physiology caused by glucocorticoids is suppression, I repeat, suppression of osteoblast activity. Most probably a block in cell-to-cell signaling inhibits osteoblast differentiation. The diminished productivity of osteoblasts is probably due to a decrease in their longevity. Histomorphometric data support the hypothesis of depressed osteoblastic function. First, the dynamic data showed depressed indices of bone formation, particularly a low mineral opposition rate. The number of osteoid seams is less. Second, trabecular thickness is markedly decreased. Unlike the disconnected trabeculae seen in senile osteoporosis, trabeculae remain connected in corticosteroid-induced osteoporosis. So, in other words, there is a difference in the trabeculae between the senile and the glucocorticoid osteoporosis. Okay, so you have to pay attention to this. I don't want to end up repeating. Glucocorticoids may also enhance resorption, although to lesser degree, then they suppress osteoblast. Okay? Glucocorticoids reduce the efficiency of calcium absorption by direct effect on the intestinal mucosa and also on the modulation of 1,25-dihydroxy vitamin D receptors. As a result, increased parathyroid hormone secretion responding to low calcium enhances bone resorption. Treating corticosteroid-induced osteoporosis is problematic because the steroids usually cannot be discontinued. A shift to alternating day regimens may be beneficial. Calcium and vitamin D supplementation may minimize the steroid effect on bone. Secondary amenorrhea, another cause of secondary osteoporosis, is a common syndrome in the United States in young women with anorexia nervosa and in young female athletes. Unfortunately, many of these women develop complications of osteoporosis while they are young. Anorexia nervosa and other eating disorders affect at least 7 million young American women and 1 million men. Girls with this disorder have a 20 to 25% reduction in mean lumbar spine density, and some even sustain compression fractures. Many young females, athletes, also suffer from osteoporosis as evidenced by significant decrease in the lumbar spine height, as I showed you the figure before. At least 20% will have an eating disorder, as in anorexia nervosa. Two factors contribute to osteoporosis in young female athletes. First, the young female athletes tend to be malnourished because being thin is usually important to athletic performance. Second, as many as 50% of high-performance female athletes, particularly endurance runners, are amenorrheic. Diabetes. Insulin-dependent diabetes is also associated with osteoporosis. The cause of reduced bone mass in diabetes is unclear. Insulin deficiency may be associated with deficient osteoid synthesis, and some patients may metabolize vitamin D abnormally. Hypercalciuria is common in diabetes. Serum parathormone and vitamin D levels are usually normal in these patients. The bone loss, I repeat, this is an important question. The bone loss in diabetics is usually cortical, not trabecular, and is often detectable as early as 2 to 3 years after the onset of clinical disease. Although osteoporosis complicates some cases of diabetes, the incidence of fractures is not increased. Smoking and alcohol abuse, I repeatedly said that smoking and alcohol have a deleterious effect on the skeleton. Although people often engage in both these bad habits, simultaneously, each habit probably has independent and additive effects on bone. Heavy alcohol intake has been associated with reduced bone mass, but the reduction in bone mass is probably multifactorial. First, alcoholics, poor eating habits that lead to malnutrition. Second, calcium and vitamin D absorption is diminished in alcoholics as a problem arises from liver and pancreatic disease. Third, alcohol appears to have a direct, I repeat, a direct toxic effect on the osteoclast. So it forms bone less. So I repeat, calcium and vitamin D absorption is diminished in alcoholics. Why? Because we said that they have liver and pancreatic disease. So they don't have the necessary elements for absorption. And of course, the effect on osteoblasts, and they have poor eating habits. Heavy smoking also enhances bone loss. Female smokers have been shown to have a lower bone mass and higher rates of vertebral fractures than non-smokers. The mechanism of this effect is not clear. One possibility is that smoking alters the metabolism of estrogen and reduces the biologic effectiveness. However, the bones of men are also adversely affected by cigarette smoking. Osteoporosis in men. Although osteoporosis primarily affects women, men also suffer from this disorder. Although they do not experience the same accelerated phase of bone loss due to estrogen withdrawal, men lose about 3 to 4% of their bone mass per decade, 3 to 4% per 10 years, and per decade after the age of 40. As a result, 30% of all hip fractures occur in men. They also suffer vertebral fractures, but at a rate of 1/2 that of women. Factors causing bone loss in men are the same as those which cause senile osteoporosis in women. These include a negative calcium balance, a lack of exercise, and a reduction in osteoblastic bone formation. Also, similar to women, men suffer from secondary osteoporosis, particularly that caused by corticosteroids. Two additional osteoporotic syndromes occur in men: osteoporosis due to hypogonadism and idiopathic osteoporosis. About 30% of osteoporosis in men due to long-standing testosterone deficiency. This syndrome most commonly presents when men are in their 50s, and they usually have a long history of hypogonadal symptoms such as decreased libido. It causes in these men include castration, previous testicular inflammation, hyperprolactinemia, and pituitary dysfunction. This is readily diagnosed by low levels of serum testosterone. Osteoporosis in hypogonadal men is a high turnover bone loss, similar to that seen in estrogen withdrawal in women. The second syndrome is idiopathic osteoporosis, and this is a premature or exaggerated involutional bone loss which occurs without an identifiable metabolic or genetic cause. This occurs almost exclusively in men and accounts for at least 30% to 40% of all cases of osteoporosis in men. Affected patients usually present between the ages of 20 and 50 with a vertebral fracture. By contrast, men with senile osteoporosis usually do not present until after the age 70. Idiopathic osteoporosis shares some clinical and radiographic features with mild type 1 osteogenesis imperfecta. Also similar to type 1 osteogenesis imperfecta, histomorphometric studies show low bone turnover, a finding suggestive of depressed osteoblast function. These diseases may be distinguished because men with idiopathic osteoporosis lack blue sclerae and the family history of fragile bones. Juvenile osteoporosis can also occur in children, but in most cases, an underlying cause is identifiable. These include rickets, glucocorticoid therapy, or an infiltrative neoplasm. Genetic disorders, particularly osteogenesis imperfecta, cause osteoporosis in children. A few children develop osteoporosis with no identifiable metabolic or genetic abnormalities. This rare syndrome, known as idiopathic juvenile osteoporosis, it affects children between the ages of 4 and 16. The remarkable feature of idiopathic juvenile osteoporosis is its reversibility. Usually, children spontaneously regain bone mass after 1 to 4 years of illness. The clinical features of idiopathic juvenile osteoporosis are characteristic. Typically, a previously healthy child, about 10 years old, presents with the insidious onset of pain in the back and legs. Physical examination is normal except for bone tenderness. More severely affected children may have mild kyphosis. They can even have a pigeon chest deformity. All serum biochemical parameters are normal. Radiographic study demonstrates severe osteopenia and lower extremity metaphyseal impaction fractures. The distal tibia is particularly susceptible. In the spine, the vertebrae may be collapsed or wedged. The cause of idiopathic juvenile osteoporosis is unknown. The reversibility of this syndrome and histomorphometric studies, which show increased bone resorption, suggest a similarity to disuse atrophy of bone. Idiopathic juvenile osteoporosis is caused by a temporary dissociation between mechanical forces and bone formation. Supportive care is the most important therapy for juvenile osteoporosis. Evaluating patients for fracture easily. Patients who suffer fractures with little or no trauma should be evaluated for metabolic bone disease, especially if the patient age is 50 or younger. First, if the osteopenia is not apparent on plain radiographs, both young and old patients should have densitometry studies to establish if bone loss is present. If osteopenia is present, patients should be carefully evaluated with protocols to rule out specific causes of osteopenia, most of which are treatable. Elderly patients should be similarly evaluated before assuming their bones are weak because of old age. You should do a DEXA scan, bone scan, take a proper family history, watch out for poor dietary habits, ask if the patient has any diseases such as scleroderma or rheumatoid arthritis and is on steroid therapy. Ask if the patient had any gastrointestinal therapy to rule out Whipple's disease, Crohn's disease, ulcerative colitis. Smoking and alcohol abuse should be taken into consideration, and the history of bed rest. Always, always ask for the list of tests that I have on this slide and request a DEXA scan, quantitative computerized tomography, and rule out a medium bone scan or ask for one to rule out focal conditions. Also, don't forget about these conditions. These are known to be associated with osteoporosis. The first step in evaluating a patient who fractures easily is to exclude a neoplastic or hereditary disorder. Multiple myeloma, the most common infiltrative disorder which causes osteopenia, can by a serum protein electrophoresis, if negative or positive, negative immune fixation electrophoresis, urinary electrophoresis, Bench-Jones protein, etc. You should evaluate these patients. Leukemia may be excluded by blood count. The principal hereditary disorder to be ruled out is undiagnosable type 1 mild osteogenesis imperfecta, because all patients with type 1 osteogenesis imperfecta have loose sclerae, and many have a family history of easy fracturability. This disease can usually be excluded by doing these tests. After ruling out a neoplastic or hereditary disorder, the syndrome of secondary osteoporosis excluded. These include specific endocrine abnormalities such as hyperparathyroidism and osteomalacia. And only when these disorders are excluded can a diagnosis of idiopathic or senile osteoporosis be made. Localized osteoporosis, you should all know, unlike the generalized osteopenia, which occurs in metabolic bone diseases, osteoporosis can occur in only part of the skeleton or even in only one bone. This pattern of bone loss is known as localized osteoporosis. This is caused by local vascular, neurogenic, or mechanical disturbances rather than a systemic condition. There are three well-defined syndromes of localized osteoporosis. One is disuse atrophy, transient osteoporosis, and reflex sympathetic dystrophy. These are three well-defined syndromes of localized osteoporosis: disuse atrophy, transient osteoporosis, and reflex sympathetic dystrophy. Transient osteoporosis is a localized osteoporosis, but unlike disuse atrophy, this syndrome is not associated with disuse immobilization. The cause is unknown, although bone loss is probably initiated by marrow edema and possibly transient ischemia. Transient osteoporosis usually affects the hip, although the knee may also be affected. Patients with transient osteoporosis of the hip are usually men between 27 and 61, or women in the third trimester of pregnancy. Some patients have a history of trauma. They present with acute hip pain. They have a limp and limitation of motion. Symptoms worsen for a few months and then begin to improve. There is complete clinical resolution in 4 to 11 months, means 6 months. Symptoms resolve in pregnant women after delivery. As many as 41% of patients have a recurrence in the same hip or in other sites, a syndrome known as regional migratory osteoporosis. Plain radiographs in the early phases of this syndrome are unremarkable. However, the MRI shows changes very early. The T1 weighted images show low signal, and the T2 weighted images show high signal intensity, indicating bone marrow edema. If you look over here, you see that there is a high signal intensity on the right side of the hip. You see the edema. It's filling the femoral head and neck. These changes involve the entire femoral head and often extend into the intertrochanteric region. Later in the evolution of this disease, the femoral head and intertrochanteric area show diffuse, ill-defined osteoporosis. Plain radiograph of the image in the previous slide is shown over here. You see the increased density on one side, while the other one, there is diffuse osteopenia. Histologically transient osteoporosis is characterized by bone marrow edema. The edema appears as an amorphous, faintly eosinophilic material between the marrow fat cells. Dilated, congestive, small vascular spaces are also present. Trabecular bone shows many resorption cavities, which in severe cases remove entire trabeculae. Seams of new woven bone are also present. Photomicrograph of the bone marrow edema is shown over here. The fatty marrow is replaced by pink edematous fluid, and you see in between it is osteotissue lined by osteoblasts. The treatment of transient osteoporosis is pain management and protection of the osteopenic bone. Lesions resolve spontaneously. Although recurrence is possible, some surgeons treat this disease with decompression core biopsy. Transient osteoporosis of the hip is often confused clinically with osteonecrosis. However, in osteonecrosis, an MRI demonstrates a discrete zone of signal change rather than a diffuse zone characteristic of transient osteoporosis. In addition, the bone shows histologic features of necrosis. in osteonecrosis. Okay? Also, unlike transient osteoporosis, osteonecrosis does not, I repeat, does not resolve spontaneously. Despite these differences, transient osteoporosis of the hip may, after all, be a precursor process to osteonecrosis of the femoral head. If this hypothesis is correct, then only a rare, severe case of transient osteoporosis progresses to osteonecrosis. Reflex sympathetic dystrophy, also known as Sudeck's atrophy. It's a regional osteoporosis in an extremity due to exaggerated vasomotor response to pain or injury. A resulting hyperemia leads to rapid bone resorption and painful soft tissue swelling. Most commonly, a hand or foot is involved, although the process occasionally affects an entire extremity. The knee is also a common site. This disorder occurs, although in varying degrees of severity, in as many as 5% of patients with limb trauma. Some studies report an incidence of 20% following a Colles fracture. Other initiating conditions are joint injuries, limb surgery, or spinal degenerative disease. Reflex sympathetic dystrophy may also involve the arm following myocardial infarction, a condition known as the shoulder-hand syndrome. Reflex sympathetic dystrophy is almost always bilateral, but one extremity is usually affected more than the other. This is something you have to keep in mind. In one extremity, it is severe. In the shoulder-hand syndrome, for instance, the other one, it's hardly affected. The clinical features of reflex sympathetic dystrophy are known as causalgia. Typically, a man or woman over the age of 50 develops this syndrome after trauma to a limb. A few days to a few weeks after the injury, the hand, foot begins to swell, and there is intense burning pain and hyperesthesia. These symptoms usually continue for several months, during which time the involved area becomes stiff with flexion deformities. Atrophy of the skin and muscle occur in the late stages from 6 months to a year. After the onset of skin is shiny, smooth, and there may be pigmentary changes, hyperhidrosis, and hypertrichosis. Radiologically, at all the bones in the affected portion of the extremity show patchy demineralization. The demineralization is ill-defined and is most pronounced in periarticular regions, particularly in the metaphysis. This is the X-ray of a hand in reflex sympathetic dystrophy. There are diffuse zones of osteopenia throughout the bones of the hand. Intracortical linear lucencies and endosteal scalloping are also characteristic. Bone scans show increased radionuclide uptake in the periarticular region, a change which usually precedes any plain radiography abnormalities. Histologically, the bones show evidence of increased osteoclastic resorption and increased vascularity. The synovial membranes from the joints adjacent to the involved bone, capillary dilatation and proliferation, fibrosis, and foci of chronic inflammation. Okay, we'll take a 5-minute break, and then we'll carry on to Paget's disease, followed by periprosthetic infections. I hope I did not bore you. شو يا خالد؟ يا خالد.
دكتور جون،
ايه
كل شيء تمام، بالعكس يعني الكل مبسوطين ومحاضرة شيقة.
ليك أنا بدي أقول لك عطيتهم الأوستيوبروسيس كقصة، لأن for me I think as an orthopedic surgeon I feel that osteoporosis is boring.
يعني no, but يعني it's a big subject and يعني common. They must know that this is a common.
They should know it. They should know it.
They should know
They
it.
should know how to treat it.
How to treat, how to diagnose it.
I agree with you. The next topic is Paget's disease and periprosthetic joint infections. I call this topic interesting. It's an interesting part.
دكتور عبد الرقيب الشاري ومدرب مشرف مركز كبير هنا معنا في عاوز يسألك يا دكتور.
خليه يسألني. He's most
Hello,
welcome.
Dr. Jone.
Hi.
Nice to hear you. I want to ask you your experience for treatment of challengeable, this very common disease, osteoporosis. What's your experience for effective treatment for such condition?
For a changeable. Look, let me tell you. It depends on the age of the patient. How old this patient want to ask about?
Yes.
Yani, if the patient
over 60.
60. Let me tell you, it depends on the severity of the osteoporosis. Let me tell you something. I routinely do a DEXA scan, and I determine the T-score, how low it is. If it's very low, and the patient
very low,
very low and diffuse and severe generalized osteoporosis.
So in this patient, especially if I gave him biphosphonates, or I gave them this long year action of biphosphonates, gave them calcium, gave them vitamin D3, gave them a combination of calcium and phosphate, and the patient did not improve. What I usually give, believe me, I have a vast experience on Fortio. I'm having very good results.
Fortio, how much period? Fortio, for how much period you give?
I don't give it more than 2 years. On the average, I'm giving it less than 2 years. Why? Because we have no evidence what happens after 2 years. Then some say that there may be a high incidence of cancer, of tumors.
Yes.
My experience, I've treated around 50 patients with Fortio, and I have been pleased. Let me tell you about Fortio. Fortio increases the bone quantity per year. It increases it percentage-wise between 3 and 5%, which is very important. Second of all, Fortio on microfractures, on all types of fractures, it promotes healing very quickly. هلا بدي لك شيء بيجيك على الامرجنسي روم حدا عنده يا burst fracture يا compression fracture وقاعد عم يقول موجوع.
Yes.
You give them Fortio for 2 weeks, you see that this patient has no pain.
After 2 weeks.
After 2 weeks, I've seen this.
Nice.
Another
But
point,
unfortunately, 40 is not available in our country.
you should request it.
From outside, yes.
Another important. What I've taught you, why you should explain this to the people. Fortio should be given to non-unions. I've seen patients with non-union fractures that I've given Fortio, 134 paratormon. I've given them Fortio. And to my surprise, these fractures have united.
Oh, nice. Nice.
It's a good medication, but let me warn you.
Yes.
You should follow up your patient well. You should do various types of studies on the liver, the kidneys, when you're giving Fortio, so as to prevent any harmful side effects.
Okay, nice.
Did I answer your question? Calcitonin is a good medication, an immediate medication. You can give it for 1 month in patients who have pain. The effect of calcitonin is that it encourages calcium to be deposited in bone.
Yes. Also has a negative impact on osteoclast.
Parafollicular cells.
Also, calcitonin has a negative effect on osteoclast.
On osteoclast, of course, it acts. It holds a gun in the face of the osteoclast. It does not let the osteoclast act on bone, and eat up bone or undergo lysis. It interferes with the interleukin-1, with the interleukin-6, all these cytokines which activate the rancle, which acts on the osteoclast or stimulates it to eat up bone within Howship's lacunae. What I'm telling you, I'm very happy from the question that I was asked. In my opinion,
thank you.
Interactive education is very important. Listening to discussions is what remains in your head. هيدي اللي عم بقولكم إياها يا جماعة. This is what is important. And you can do it. You have brains in Yemen. Why not make use of it? Everyone should read. I expect from everyone يبيض لي وجهي بهالبورد exam بالwritten وبالاورال. بدكم تقروا. وقلت له للدكتور خالد, he can take my lectures, distribute them, and the students should memorize them. I wish I had more time to teach you, but this is it. I'm trying my best. هلا بدي انوعد من يلي عم بيسمعوا هاللكشرز يبلشوا يعطوا اللكشرز ذاتهم للي اصغر منهم.
Yes.
By teaching, you are learning.
Yes, active learning is very important. For receiving knowledge, you have to demonstrate for others.
I was head of surgery and orthopedic surgery and general surgery at the Lebanese University. When I came in, I had residents that did not know much. I gave them lectures, and they listened to these lectures repeatedly. By the time they became fifth year, they did not need me. They started giving the lectures to the younger generation.
Yeah, right.
You see, at the American University, likewise, we tell them make slides. Organize your knowledge of how to make a short slide, not like my slides, shorter even. You should be able to explain better. Train yourself. By repetition, you will learn. And this is what I tell my students. At the Lebanese American University, I was program director until last year. And I taught the residents from the beginning of the university to the present. And now I believe that their residents are very high quality. And this is how they learn. They teach each other. They ask me questions. They shoot at me questions. The fact that you don't ask questions, let me tell you, it means that you don't know enough.
Yeah.
I'm not a spooky man. If somebody asks a bad question, I try to make it more interesting. Then by
Yes,
asking questions, you are learning.
Yes,
And
yes.
please, don't ask a question just to show that you're asking. Ask a
Yeah.
question to learn and to teach. And that's it.
Yes.
تعرف انه كنا رايحين دغري من بعد الاجتماع بالبورد الاربعاء والخميس والجمعه كنت معزوم على بنغازي كجروب كنا رايحين نحكي بس على الديجيتال education, interactive education, and how to improve education in universities. هلا we postponed it and there have been many victims of this flooding.
Yes, yes.
Yes. Okay?
Okay.
شرفنا حكيم.
Thank you for this advices. There is some phrase said, if you want to learn yourself or teach yourself, teach others.
Hey, of course.
Yes. Okay, thank you for advice. Thank you very much.
Why? If you want to teach yourself, you teach others. By teaching, you are memorizing what you are giving to others.
Yes.
By repetition.
Very for...
Exactly.
Yes.
بعدين شغلة تاني, let me advise you.
Yes.
When you're giving a lecture, what you should do, you should aim as to try and represent your talk by photographs or by tables. إذا بتقشعوا مثلا هلا حطيت لكم Paget's disease بس حطيت لكم photographs, حطيت لكم anterior bowing of the leg, bowing of the femur, increased sclerosis, stress fractures on the convexity of the bow. This is very important. Looking at these photographs will not let you forget Paget's disease easily. Okay?
Yes.
بعيدي وأنا لكم الحقيقة, I back the Yemenis. I like the Yemenis.
We know that. Thank you for your so much support. Thank you.
I feel bad for the Yemenis because they passed through a difficult time like we have passed in Lebanon.
Yes. Thank you.
مش هيني حياتنا.
Yes.
You know, I'm an old man now. بقول لك إياها, I can be honest. Throughout my life, I did not really have a peaceful week. بقول لك إياها, it's very difficult. Life in our regions has become very difficult.
Very difficult, yes, you're right. Thank you very much, Dr. Jone. Take your time for rest and we reestablish.
أنت ريحتني. أنت ريحتني بصوتك.
Thank you. Thank you very much.
I'm going to start and I still have half of the lecture.
Okay, no problem.
Okay.
Thank you.
We're going to talk about Paget's.
I have to call it with you now.
Well, thank you, Dr. Jone. Now you can start or take rest?
I will start.
Okay, thank you.
In the late 1800s, Paget's disease was discovered by a fellow who visited the doctor, and he was noticing that his hat was becoming tight on his head. He had to change many hats. So what do you think was happening? The skull was enlarging and the hat remained the same size. فصفى بده يغير الهات. Okay? And it was called Paget's disease after James Paget, who described it. It's a localized disorder of bone remodeling that causes dense sclerosis, enlargement, and deformity of the affected bones. So I'm going to that. Look, you have enlargement of the bone in this slide. You have bowing of the bone due to deformity. You have stress fractures, and you have transverse fractures of the subtrochanteric bone in solid bone. يا جماعة إذا بتطلعوا بالbiomechanics, when you have a solid piece of bone and you have a hollow piece of bone, إذا بتقشعوا بالاوستيوبروسيس so as to increase the stress of bone that is able to bear, تطلعوا على the diameter of the bone. Why does the diameter increase? Why? Because it increases the mechanical force to be applied on that bone. If the cavity becomes wide and the width of the canal does not increase, that bone will become weaker. Now, if you look over here, you have solid bone. Don't think that solid bone is strong. It cracks. I'll tell you this. If you look at a condition which is called osteopetrosis, osteopetrosis, you have no medullary cavity. So what happens? It's called chalk bone. It's hard bone. It's thick bone. And when it fractures transversely. This is weaker bone. This disease is more prevalent in individuals of Northern European, North American, Australian descent, and is rarely seen in Asians. I'll be honest, I've seen a few cases. I've seen localized cases. I had one in the metacarpals. I had one in the vertebral body, which we call it an ivory vertebra. And I've seen one with a cotton wool appearance in the pelvis and one in the skull. So these are cases for a man who has over 50 years of practice. This is not many. But in Europe, in Australia, you see it much more often. The affected individuals are generally older than 55 years and rarely younger than 40 years. Many patients are asymptomatic, and the disease is often discovered on radiographs taken to diagnose other conditions, mish Paget's disease. And wow, you say, I see this osteoblastic bone, it's localized. Don't immediately say that this is an osteosarcoma. You have to learn to make a proper differential diagnosis. The disease affects both osteoclasts and osteoblasts. However, the cause is unknown. We don't know what the cause is. 2 studies of large kindreds have identified a gene that may increase the susceptibility to the disease. Viral inclusion bodies resembling those of RNA, and they are known as paramyxoviruses. يا شباب درسوها هي سؤال بنحب نسأله إنه what is found in patients with Paget's disease. You see that they have something like a paramyxovirus. Could it be related to viruses? We don't know. Also, respiratory syncytial virus and measles have been found in the osteoclasts of involved bones in some patients. The limited locations of the disease in the skeleton, the increased levels of inflammatory cytokine and interleukin-6 in phagocytic foci, and the fact that new disease foci do not form once the disease has become established. And it's not a progressive disease. Once it's established in one bone, it does not appear in other bones. It can appear in multiple bones at once, but if one begins with the localized and it's nearly maturing, it won't affect the other area. 3 histologic phases of Paget's disease have been observed. Initially, a marked increase in bone resorption is seen, with an increase in the number and size of osteoclasts. Radiographs at this phase show lucency in the affected bone. In long bones, wedge or flame-shaped lucency begins in the metaphysis, and points toward the diaphysis. This is one of the beginning signs of Paget's disease. This lucency advances into the diaphysis and progresses along the lens of bone at the rate of 1 centimeter per year. This is the lucency. It stops, and then it begins to mine. This is what we call the wedge sign or flame-shaped lucency. This is the onset of Paget's disease, and then it starts progressing. This is another one. Hello, ala lucency. When it progresses, it becomes more or less like the middle slide, and then complete, where you have blastic and lytic lesions at the same time. So anybody looking at these slides, if you look at the middle and the extreme right-hand slide, you say, my goodness, this looks like an osteosarcoma. You have to think of a differential diagnosis. Mind you, in these cases, if you do an alkaline phosphatase, it will be elevated. So you have to think of this. Look at this. This is how it's beginning. And in the skull, they have a cotton wool appearance. They have multiple lytic lesions. They have osteoclastic circumscriptor, multiple lytic lesions of the skull. And they have sclerosis of the skull with enlargement. So we have first the osteolytic phase, where bone is destroyed. Then it changes. And we get in the osteoblastic phase. This is characterized by a rapid increase in osteoblastic activity. So you have the osteolytic phase, then you begins by this wedge translucency moving downward at the rate of 1 centimeter per year, and gradually it's becoming replaced or invaded by osteoblastic activity with resultant increased new bone formation, and the alkaline phosphatase levels is high. The new bone forms in a disordered pattern with widened lamellae and irregular cement lines. Just look at this. They have, if you look at the neck of the femur, this patient has a vertical stress fracture, and he has an osteoblastic lesion of the head. Look at the vertebra. This is what we call an ivory vertebra. The differential diagnosis of an ivory vertebra, it can occur in Paget's disease, it can occur in prostate carcinoma, it can occur in Pome's disease of multiple myeloma, and this is it. You have to make a differential diagnosis. This is the skull. This is the osteolysis on the frontal aspect of the skull. And it's we call it a circumscriptor osteolysis. And then on the right-hand side, You have the blastic phase, which is a cotton wool appearance, just like cotton, and the skull is becoming larger, and it is a combination of lysis and blastic formation. In the second phase, the alkaline phosphatase is high. Woven bone rather than normal lamellar bone predominates. What we mean by woven bone is irregular bone. It's not mature bone. Lamellar bone is normal. You have to pay attention to the Haversian canals and of how well they are organized to be able to say whether it's woven or lamellar bone. Mineralization occurs twice the normal rate. Radiographs taken during this phase show previously loosened regions converting into radiodense regions, and in the final phase, both osteoclast and osteoblast activity decrease. So the active phase starts osteolysis, then it's replaced by bone formation of woven bone, and then as both exist, then these two phases decrease, but you have deformities set in. Radiographs show densely sclerotic, deformed bones with the thickened trabecular pattern and cortices that characterize this disease. Most patients with Paget's disease are asymptomatic. Patients with symptoms report bone, joint, or low back pain. Let me tell you, I've operated many patients having Paget's disease with complete destruction of the hip that I had to do a total hip arthroplasty. One of my warning points, beware, prepare a lot of blood on these patients because they tend to lose a lot of blood because the bone is hypervascular. This is a patient with Paget's disease. One of the points I want to warn you is that this bone serves as a ground substance, which is very vascular, and is the site for metastatic disease to settle down. If you look at the upper left hand of this slide, you see cancer growing in Pagetoid bone. In the middle left-hand side, you see the ivory vertebra, which appears larger, and there is an increased density. In the lower left-hand side, the disease is throughout the pelvis. And when I tell you I've seen this in multiple areas, most of the cases were in the pelvis. They usually have an enlarged head. These patients don't hear well because they have otosclerosis. And the output, they have a high cardiac output, and that's why they bleed a lot. They have bone pain, they have back pain, they have hip pain, they have flexion contractions of the knee, and they have stress fractures. This is a characteristic radiographic finding of the tibia, which includes thickening, bowing, and coarse trabeculation with advancing radiologic wedge. And this is a section, a pathologic section, which shows intense osteoclastic and osteoblastic activity. And this is what we call the mosaic bone appearance. I want to show you, this is, I hope you're seeing this arrow. It's pointing around Hoschip's lacunae, and you see an osteoclast in the Hoschip's lacunae. And if you take an electron microscope of this, you see that they have pseudopods, which are gradually dissolving bone, eating up of bone. And this shows you an electron microscopic picture of a multinucleated osteoclast with nuclear inclusions. That's why we speak about viruses, paramixed viruses. A bone scan will be positive during the early phases of the disease and may help demonstrate foci before they become evident on plain radiographs. Paget's disease of the spine commonly affects the lumbar vertebrae, resulting in the picture frame appearance of these vertebrae with their thickened end plates and thickened subcortical bone, as I have shown you repeatedly. Enlargement of the vertebrae, I showed it to you, can cause nerve root compression with associated pain, weakness, and numbness in the region innervated by the affected nerve. Lesions located adjacent to the joints may cause osteoarthritis. وصدقوني فرجيتكم إياها على الهip, where it is totally involved with degeneration and even with the insufficiency fracture. Fractures are more common and frequently occur on the convex side. I'm going to recall what I told you in the past. Osteomalacia, the stress fracture or insufficiency fracture or fragility fracture, occurs on the concave side of the bone. Paget's disease occurs on the convex side. هل فرق ما بين الاثنين? We asked this question. At least I asked this question. Paget's disease also can precipitate high output cardiac failure due to increased vascularity of the affected bones and the subsequent demand on the cardiovascular system. Patients with suspected Paget's disease should have plain radiographs taken of the affected areas. Biochemical markers of bone turnover, such as serum alkaline phosphatase. In addition, urinary collagen breakdown, peridinoline markers should be searched for. It should be measured during the initial evaluation, followed during treatment. Symptomatic patients should receive biphosphonates, oral therapy with alendronate, residronate, toluidronate, prevents the mineralization defects associated with prolonged etidronate treatment. Calcitonin administered as a nasal spray is an alternative for individuals who cannot tolerate biphosphonates. However, its effectiveness is variable. Patients with severe osteoarthritis may be helped by joint replacement procedures, but the high vascularity of their bone often increases intraoperative bleeding. So, fellows, prepare a couple of units of blood when you're going to operate on these patients. Hypercalcemia also may occur after major orthopedic procedures in patients with active disease. And beware of this. You have to lower it because it will deposit in the kidneys and the soft tissues. An unusual complication that occurs in approximately 1% of patients is the development of high-grade sarcoma within a Pagetic lesion. These tumors most commonly are osteosarcomas, fibrosarcomas, and chondrosarcomas. Furthermore, carcinomas occasionally metastasize to pediatric foci. يا جماعة, why? Because they are hypervascular. And when you have a metastatic lesion, it's searching for an area of hypervascularity to obtain its nutrition. Why does metastasize to the spine so often? Because it's quite vascular, because it consists mainly of cancellous bone. So you have to pay attention to these points. Okay, now this emphasizes the need for periodic radiographic and biopsy of lesions that appear to be evolving. This is the first section. The second section is the management of pre-prosthetic joint infection. And this is really rather, it's not long, it's around a 3/4 of an hour lecture. And I will be giving you this because I want to try and finish as much as possible for you to your board exam. Are there any questions for me?
Dr. Jone,
ما بسمع.
Dr. Jone,
كمل.
now you will take rest. You take rest or what?
And I don't need rest.
Okay. As you
I can speak for 10 hours. Don't worry.
Thank you. الله يعطيك العافية.
The only time I need rest is when I want to go to the bathroom. And I will let you know. Okay?
Okay. Yeah. Thank you.
Prosthetic infections, ya Shabab, is your biggest problem now. In institutions, you should aim of highlighting the best way to sterilize your operating rooms, the best way to sterilize your assistants, the best way to rule out carriers of infection, the best way of ruling out an air conditioner which is giving microbes. You have to be aware of these things. It is usually the infectious disease man who does this investigation. And I'm proud to say that Parisi is a man of our regions who is an authority on these cases and this subject. Now I will start the lecture. Despite the great success of total hip arthroplasty, deep infection remains one of its most devastating complications. I say devastating. You know, many of our operations keep us awake all night, but this is one of the ones that let us feel miserable when we are awake. This results in prolonged and complex treatments involving reoperation and ultimately poorer outcomes. And the cost to the patient is tremendous. It's enormous. The incidence is approximately 2% for the knees and 0.5 to 1% for the hips. Why? Because in the knees you have an empty cavity. You can easily have a good zone for organisms to grow. Infection is the third most common reason after instability and loosening for revision surgery following total hip arthroplasty, and was by far the most common reason for removal of the prosthesis. Prevention depends on optimizing patient selection and other host factors. You should choose your patient properly. You should look for the comorbidities. You should do tests on the patient, do a leukocyte count, do an albumin level. If they don't have the proper level, don't do the surgery. يلعن أبو المصاري. If you're going to have a patient that would let you lose 10 times the amount you could gain by doing the operation. You should improve the surgical suite environment. أكره شيء عندي لما أكون عم بعمل عملية وكلهم عم بيحكوا. لما عم بعمل عملية وبكون 20 واحد فايت وظاهر على أوضة العمليات. لما بعمل عملية وبلاقي حدا عم بيمرق حد الطاولة ما عم ينتبه عم بيدق بالروب تبعه على الطاولة. يا جماعة, you have to improve these cases. You have to improve the environment. And we should give administering prophylactic antibiotics. The most common infecting organisms are gram-positive cocci, staph species, but some infections may be polymicrobial. Let me tell you, the most frequent organisms are Staph aureus and Staph epidermidis. You have other organisms, as I will tell you as we go by, but these are the most common. 60%, these are the organisms. The diagnosis is made by a high level of suspicion, a thorough history and physical examination, screening with erythrocyte sedimentation rate and C-reactive protein, selective use of hip joint aspiration. If these screening laboratory tests are abnormal, or if the clinical suspicion for infection is high. Synovial fluid obtained from an aspiration should be sent for synovial white blood cell count and with cultures. They should be sent for aerobic and anaerobic and fungal cultures, and even for tuberculosis. You say that for tuberculosis, it's very difficult. What you should do with the specimen, put it in a centrifuge it, and take the sediment, and you culture this, and you do your investigation on this. You concentrate the microbes. You should concentrate the microbes. Successful treatment usually depends on the duration of the infection. In acute cases, less than 3 weeks, debridement and component retention in post-operative and acute hematogenous infections, although staph infections seem to do worse with this strategy. So you have to decide on the period in which the infection was. If you've done surgery and the patient demonstrates signs and symptoms of an infection, and let's say within 1 month, you are justified to go in. You don't need to remove the prosthesis. You need to remove maybe the polyethylene component. You have to irrigate well with the dilute solutions of, first of all, let's start with distilled water, then dilute solutions of betadine, dilute solution, clean up the area, remove all the infected tissue, and close. You don't put drain, and you give this patient antibiotics. Of course, you have to do the cultures. You have to take 3 different cultures from different areas, send them to cultures. If you find the same organism, in the 3 different cultures who confirmed the infection. You give the patient 2 to 3 weeks of IV antibiotics, then another 3 to 4 weeks of oral antibiotics. This is what should be done. In chronic infections, they are treated most commonly using a 2-stage exchange protocol, although there is increasing interest in the use of a 1-stage exchange. And this is commonly used in Europe. There are innumerable factors that may contribute to or directly result in deep infection following total hip arthroplasty. These are organized into 3 groups: the host, the local wound environment, and the microbiome. By investigating and addressing how these entities contribute singularly and interact with one another, a better understanding of the disease process and its treatment will emerge. The incidence of deep infection following total hip arthroplasty in the early experience, we all know about John Charnley, was 9%. 9%, it was hell. But fortunately, this was reduced to 1.3% in his next cohort of patients. But why was it reduced? The reduction was attributed to the routine use of prophylactic antibiotics before the surgery, let's say around a half an hour before the surgery. And if the surgery is long, more than 4 hours, another dose of broad-spectrum antibiotic is given. Air cleanliness, meaning by the air conditioner. In the past, we used to give horizontal line air conditioning. Now we give vertical airline. Why? Because we think that this disturbs the surrounding particles in the room much less and promotes it to land in the wound. Nowadays, there are articles that state that there is no difference whether we use it or don't. And then body exhaust attire. I'll tell you, you see in these operating room, you see these exhaust suits that the surgeon is using, of how impressive it is. But what Charnley did, he had a tube from the bottom of his suit or the protection gown going outside the operating room, so that whatever sweat, whatever dirt, whatever condition that occurred in was drained outside the operating room. Now, these exhaust suits that they are wearing, they don't drain outside the room, and this is wrong. At present, we should do a better patient selection. We should use prophylactic antibiotic, mainly a broad spectrum like cefazolin. We should prepare our operating room much better. The patient should be calm, because we've noticed patients who are under physiologic stress have a higher infection rate. Our patients should not be malnourished. Poor immunity and normal immune response by altering both humoral and cell-mediated immunity increases the infection rate. Rheumatoid arthritis and steroid therapy increase the risk of infection. Obesity. If you look at the United States, the youngest patient having a total hip, the low weight patient, is over 100 kilos. So you can imagine that infection rises to 4.2 times. Diabetics, you should reduce the risk of infection with a hemoglobin A1C value below 7.5. You should not operate on anyone who is more than 7.5 milligrams per deciliter. The combination of obesity, diabetes, and hypercholesterolemia is a significant risk factor for complications after total hip arthroplasty. Chronic renal failure patients on dialysis and those with liver or kidney transplants are at increased risk for infection. Malignancy and those with a human immunodeficiency virus are also at increased risk. A previous infection of the native hip, of course, we all know it. They have a higher rate of infection. You should explain it to the patient, explain it to the family so that they won't condemn you. Delayed wound healing. When you do a total hip and you see that there's a delay, you should be aware of an infection. And they will have persistent wound drainage, skin lesions, dental caries. Now, let me stress something. The American Association of Dental Specialists say that this is not significant. It does not increase the infection and total hip replacement or major surgery. But this is mentioned repeatedly. And I don't like a patient coming to me saying, I'm fixing my teeth and I want to do a total hip. Urinary retention with subsequent bladder instrumentation can lead to an infection at the site of total hip arthroplasty. This has been repeatedly reported in various studies on catheterization of a patient with urinary retention, that the incidence of infection is higher. Prophylactic antibiotics, first generation, as I said, cefazolin or cephalosporin, is often given on the basis that this agent is bactericidal, therapeutic against commonly infecting pathogens, and inexpensive while possessing inappropriate half-life. Antibiotic prophylaxis with cefazolin before and after surgery was demonstrated to reduce the risk of infection after total hip arthroplasty compared with placebo from 3.3% to 0.9% in a double-blind controlled study. Hypersensitivity to penicillin. One should use clindamycin or vancomycin should be considered as an alternative. They should be administered intravenously within 2 hours preceding the incision, and peak bone concentrations are reached within 35 to 40 minutes. A multi-center prospective trial observed that when the preoperative antibiotic was given within 30 minutes before the incision, the rate of surgical site infection was 1.6% compared with 2.4% when the antibiotic was given from 31 to 60 minutes. So be careful. Don't forget about this. And I usually routinely give cephalosporin. Be at ease at mind. Try the best. And what I do is, when I'm doing a total hip, I scrub it for 5 minutes. I don't listen to anybody who say, why scrub it? I scrub it for 5 minutes, and then I apply chlorhexidine, betadine. So be careful about this. And I'll tell you what I use. I have listed them. Intraoperative redosing in the surgical cases. And if you're giving an antibiotic, you give that dose at the beginning, and if the surgery takes longer than 4 hours, you give the second dose of antibiotics. The post-operative duration of prophylactic treatment is debatable. في ناس بيقولوا اني حطيت انتيبيوتيك بقلب وقت العمليه لشو تعطي بعدين. في ناس بيقولوا give it for 72 hours. But I'll tell you something. They have found that there was no difference in treatment for 24 hours versus 3 days. Multiple other studies have confirmed that prolonged prophylactic treatment does not appear to be of benefit. Limiting operating room personnel or traffic, surgical time, and the use of iodophore incorporated drapes have been shown to reduce the risk of infection. Use of ultra-clean air operating rooms, vertical laminar flow, and body exhaust suits that drain outside the operating room have been demonstrated to favorably affect the rate of infection. However, these points have been debated. What about Gore-Tex gowns? These may be more appropriate than cotton in preventing dissemination or shed bacteria by the surgical team. The use of double gloves. I want to warn you, when you use double gloves, you have to ask for 2 colored gloves. You have to put each glove a different color to know whether it's penetrated or not, or whether it's torn or not. So don't forget about double gloves. And when you're using suction, you should change the suction tip every 20 minutes or to a half an hour. Don't forget this. These are important points. And be careful when they're changing the suction, or if the suction tip is obstructed. Don't forget that a clamp should be put on the tube as they're seeing where the obstruction is. Why? Because the fluid will reflux back into the wound, and then the drama starts. Use pulsatile lavage and antibiotic irrigation solutions. These are effective in reducing the wound bacterial load. Brown et al. Showed a significant reduction in the rate of deep infection when dilute betadine lavage was performed prior to wound closure. The most recent statement by the American Academy of Orthopedic Surgeons and the American Dental Association has reversed their previous position on standard antibiotic prophylaxis, now recommending against routine prophylaxis. The introduction of a biomaterial into the body has been likened to a race to inhabit the surface of the material between the host tissue and the bacterial pathogens. Certain bacteria may have a predilection for seeding different biomaterials. Staph aureus seems preferentially to seed metallic implants, and Staph epidermidis shows a preference toward polymers such as polyethylene and methylcrylate. Please don't forget this. I love to ask this question. Many bacteria form a mucopolysaccharide. No, it's a mucopolysaccharide. Don't forget this word. And this is a biofilm. It's a cryoprecipitate that isolates and protects an organism against any host immune response or antibiotic penetration and even mechanical debris. Let me tell you, these are fortifications, like in the war, when they build fortifications and the soldiers sit in it. this is what happens. It's a mucopolysaccharide that is formed, and it protects the bacteria from being destroyed on the surface of the implant. And to be honest, the only way we can remove it is by a process called sonication and reinserting the prosthesis in an autoclave. The bacterial glycocalyx may harbor multiple different bacterial species. This makes treatment of such patients difficult without removal of the prosthesis, because the appropriate antibiotic regimen cannot be determined. What we found out is that when we add to various antibiotics chosen rifampin, it appears to improve treatment protocols when used synergistically with other antibiotic agents. There may exist a trend toward an increasing prevalence of cultures positive for staph epidermidis and a decrease in gram-negative bacteria. Gram-negative organisms known to cause periprosthetic hip infection range only from 11 to 14%. Of all isolated organisms include Pseudomonas, Enterobacter, Serratia, Proteus mirabilis, E. coli, Klebsiella pneumonia, Actinidobacter species, Moraxella, Salmonella. Other more rare organisms that have been reported include anaerobes, mycobacteria, and fungi. I've had, in my experience, only one mycobacteria infection of the total hip. I've had fungus infections and occasional anaerobes, but the far majority were Staph aureus and Staph epidermidis. A trend that has generated extreme concern has been the emergence of antibiotic-resistant bacteria strains over a 5-year period. Nosocomial infection rates in intensive care unit patients had increased by 31% for methicillin-resistant Staph aureus and by 55% for vancomycin-resistant Enterococcus. Fortunately, these alarming trends have not been observed to the same magnitude in periprosthetic infection of the hip, but they do exist. The rate of methicillin-resistant Staph epidermidis hip replacement patients was observed to be as high as 40 of 30 positive cultures. 48% of Staph epidermidis cultures. In a single study, 35 infected cases following total hip autopsy. 54% were infected with resistant organisms, and the results of treatment for these resistant organisms were far inferior to that given for sensitive organisms with successful retention of the prosthesis in only 16%. Methicillin-resistant organisms had significantly longer hospital stays and higher risks of treatment failure and removal of the prosthesis. This further emphasizes the critical need for accurate diagnosis and identification of the infecting species and its sensitivities in providing optimal care for these patients. The diagnosis, everybody's waiting for this. Serologic testing, radiographic evaluation, conventional and occasional advanced imaging, synovial fluid analysis, microbiologic cultures, and histopathology. The criteria for diagnosis include sinus tract communicating with the joint, not within the subcutaneous, with the joint. 2 identical positive cultures from 2 different regions, or 4 of the following 6. Elevated erythrocyte sedimentation rate, C-reactive protein, elevated synovial white blood cell count, threshold 3,000, elevated percentage of synovial neutrophils, threshold 80%. Single positive culture, positive histology, or gross purulence. The range of motion of the hip should be determined and compared with previous examination findings. Guarding pain with passive motion, pain at rest, and diminishing motion are matters of concern regarding infection. A thorough neurovascular examination and examination of the skin for any remote lesions should be performed. Wound drainage should not be cultured because these results are highly inconsistent and may only confuse the clinical picture. Empirical antibiotics for wound drainage should be avoided because they suppress and delay the definitive diagnosis. Plain radiographs, rapid or progressive loosening, osteolysis, periosteal or endosteal reaction, and osteopenia. These findings, however, may have other causes, implant loosening or osteolysis within the first 2 years. Any osteolysis or loosening should let you be suspicious of an infection. Plain radiographs can be helpful should any of these findings be observed, but the lack of radiographic changes does not exclude an infection. This is a plain radiograph of a total hip arthroplasty with a cementless acetabulum component and a cemented femoral component, demonstrating significant osteolysis and implant loosening of the femoral component at 21 months postoperatively. This is highly suggestive of a deep infection. The serum C-reactive protein and ESR should be the initial screening laboratory test when infection is suspected. In a recent study of preoperative testing for more than 200 revisions, total hip arthroplasties, 100% specificity for a hip not to be infected was noted when both C-reactive protein and ESR were normal. An elevated ESR greater than 30 per hour was shown to have a sensitivity of 97% and a specificity of 39%, a positive predictive value of 42%, and a negative predictive value of 96%. If the ESR greater than 30 and CRP milligrams per liter are elevated, or if the clinical suspicion for infection is high based on history and physical examination, aspiration of the hip is recommended and the fluid obtained is sent for synovial fluid white blood count and differential and culture. Patients should be off antibiotics for at least 2 weeks before aspiration to maximize culture yield and accuracy. Recommended diagnostic criteria from several previously reported studies of periprosthetic infection of the hip and knee using ESR, C-reactive protein, synovial white blood cell count, and differential. Although these synovial tests alone may provide valuable information, the combination of these tests results with ESR and C-reactive protein results can greatly improve diagnostic accuracy. The use of biomarkers, most notably alpha defenses, has demonstrated promising results in the diagnosis of prosthetic joint infection by combining tests for elevated synovial alpha defensive levels and in elevated synovial C-reactive protein commercially marketed as Synovazor. The diagnostic accuracy of this combination has been reported to be as high as 97% sensitive and 100% specific for periprosthetic joint infection in one report. While some used this test routinely, it is most useful in cases in which results of synovial fluid white blood count, differential, and culture are unclear or discordant. يعني ما بتستعملوها إلا ما تكون عندكم doubt من the results about white blood cell count, C-reactive protein, and ESR. The most common scenario that we see is an elevated synovial fluid, white blood cell count, and differential with negative cultures. In this scenario, Synovazor testing is obtained at the time of repeated aspiration to confirm the diagnosis and the presence of a culture negative infection. When we are faced with a potential culture negative infection, we also inoculate any synovial fluid obtained directly into blood culture bottles, which may increase the yield of cultures, obtain cultures for acid-fast bacilli and fungus, which we do not normally obtain. Don't forget these acid-fast bacilli, fungus infections. Don't forget this. And hold the cultures for a full. هلا يا جماعة, I've realized that people, when I take a culture and send it and don't specify, what happens? They throw the specimen after 4 days. You should leave it for 14 days because not all organisms grow in a short while. The use of indium 11 leukocytes count, in which host leukocytes are tagged with radioisotope and reintroduced into the body. It has shown some utility, namely in its negative predictive value of 95%. The differential use of technetium and indium scans may distinguish areas of enhanced metabolic activity and inflammation. When a technetium 99 sulfur colloid marrow scan is combined with an indium scan, accuracy improves 88%. However, routine use of these studies is debatable given their high cost and the relative accuracy of synovial fluid, white blood count, differential, and culture. Newer nuclear medicine techniques such as technetium 99, immunoglobulin, scintigraphy, and 18-fluorine positron emission tomography may provide improved diagnostic accuracy. These techniques are not currently in wide use. Unfortunately, there are many clinical scenarios in which preoperative testing is unable to definitively diagnose or rule out periprosthetic infection. If the clinical picture continues to cause concern for infection, analysis of fluid and tissue around the prosthesis obtained at the time of reoperation is indicated. Gram staining of periprosthetic fluid not only has a poor sensitivity, but may also generate false positive results. It should not be done routinely and certainly should not be relied on as the only method of screening for periprosthetic joint infection. Many authors have investigated the role of histologic analysis of periprosthetic tissue in the diagnosis of infection. In these studies, an attempt was made to correlate frozen sections from the time of revision surgery with the diagnosis of infection. Although specific cutoff values are debated, likely secondary to inconsistencies in sampling technique and pathologies, the essence of findings is that the increased number of neutrophils observed in the tissue surrounding the prosthesis appears to correlate with infection. At least 5 neutrophils in each 400-time high-power microscopic fields to diagnose infection. Any test for infection will have a given sensitivity and specificity that will not perfectly predict or rule out the presence of infection around total hip arthroplasty, and even those tests considered to be gold standards. Should the clinical suspicion of infection be high based on the history, physical examination, or if the ESR and C-reactive proteins levels are elevated, the hip joint should be aspirated and the fluid obtained sent for synovial fluid, white blood cell count, differential, and culture. The synovial fluid white blood cell count were found to be 3,000 per cubic millimeter. Obtain multiple cultures, typically 3 to 5 sets, directly through the capsule into the hip from several different sites, including the most suspicious appearing areas at the time of revision. On exposure, an 18-gauge spinal needle is used to obtain synovial fluid through the capsule. Aspirate fluid through the capsule before the capsulotomy is performed. This technique allows for easy access to the synovial fluid while minimizing potential contamination that can occur when aspirated through the skin or multiple layers of tissue. A recent study found that the use of synovial fluid white blood cell count was the best perioperative test for identifying infection with 80% polymorphonuclear leukocyte cells. Aspiration can be performed either preoperatively or intraoperatively before entering the hip's capsule. The mainstays of treatment of a chronic infection include removal of the components, insertion of an antibiotic-loaded cement spacer, and systemic antibiotics for 6 weeks, followed by reimplantation once the infection has been cleared. Debridement and component retention has been shown to have a high rate of failure and seems only effective in the management of some early post-operative infections occurring within the first 4 to 6 weeks and acute hematogenous infections, although the presence of staph species in both of these scenarios seems to portend a worse prognosis for success. Now, I want to show you a few cases of mine. The incidence of infection rises with poor immune defense mechanisms, rheumatoid arthritis, diabetics, poor nutrition, the white blood cell is low, obesity, urinary tract infection. The wound, whether previous surgery or not, is a factor. Surgical techniques and the experience of the surgeon and modes of fixation of the implant, the operating room environment, OR people and laminar flow, ultraviolet light. I'd like to add noticing who are the carriers of infection through the nostrils. You should manage these carriers with mucopirocin to kill the organs. The microbiologic character of the infecting organism is also important. Cement, stainless steel, chromium, cobalt alloy, and polyethylene in vivo impair chemotaxis, phagocytosis, and the killing ability of polymorphonuclear leukocytes. The prosthesis is a foreign body. It can easily be colonized. Routine workup is a must. Aspiration, lab studies, white blood cell, ESR and C-reactive protein, and scan. Aspiration and total hip arthroplasty only if clinical suspicion exists. It may be negative in over 25% and look for glycocalyx and must be off antibiotics for 2 weeks. The operations that we do are 1 stage, 2 stage with resection arthroplasty, and 2 stage with an articulating spacer. It's okay for low virulent organisms, higher recurrence of infection, and working in a contaminated field. This is for a 1 stage. It's okay for a low virulent organisms, higher recurrence of infection, of course, and working in a contaminated field. The 2 stage with the resection arthroplasty, they have a lower recurrence of infection, and they have a difficult revision, but with soft tissue scarring. We have to be careful. The 2 stage reimplantation eradication of infection occurs in 60 to 95%, resection arthroplasty until reimplantation also. But the problem we face is that you have contractions, difficulty in removing any antibiotic-laden cement beads like gentamicin if applied. And for hips, 1 series suggested resection for 12 months with virulent organisms, and this may extend up to 6 years. The problem is, what is the result? You get a poor bone stock, you have difficult exposure, you have excessive blood loss, and you have soft tissue deterioration. These are the problems I have faced. What about the articulating spacer infection? A spacer with 4.8 grams of tobramycin per batch of pellicle cement. 2, no drains should be used. 3, tailored intravenous therapy for 2 to 3 weeks, followed by oral antibiotics for 6 weeks. The total number of patients that were studied were 8. There were 6 females and 2 males, and the ages ranged from 50 to 76 years. Cultures, gram stains, tissues are sent to lab and pathology, and a full workup was done on all patients. Aerobic and anaerobic cultures are a must. You should culture for fastidious organisms. Beware of methicillin-resistant Staph aureus and vancomycin-resistant Enterococcus species. Staph epidermidis adheres readily to polyester. This is the tobramycin. We're mixing it in Pelacos cement. We're putting the cement, we do a very poor cement insertion. The antibiotic-loaded cement is then applied over the cup and is then inserted into the acetabulum bed. The stem is prepared in the same way, and mind you, we can use the same processes after autoclaving it, and we put cement in a very bad way, just to get provided for antibiotic supply. I'm going to show you it on cases. This is a patient that was operated so many times, 4 times revision at one of the university hospitals, and then for an infection. And finally, the surgeon gave up hope. He removed the prosthesis, and he left her with a girdle stone. The patient had 6 inches of shortening. It was in a miserable state when I received this patient. I reinserted the patient after making sure that infection had subsided and reimplanted the process. The only problem I had is that I could not put the cup at the true acetabular center. I had to put it a bit high because I had so much contracted tissue that I had to overcome. She finally ended up with 3 inches of shortening, had a lift, and she was very happy after I inserted this AML solution stem. This is a patient who was 56 years old. She had a total hip. It was loose and infected. The SED rate was 70, the CRP 12, where I applied for 1 week only cement beads. And then I inserted this log ZMR prosthesis, and the cup were not cement. I removed all the cement at the end and then reinsert. Patient was great, doing great. This is a patient that was operated at the University Center, and this interim prosthesis was prepared handmade. They used the aseptic syringe gumbo cup to fill it up with cement, and they applied it over here. The patient came to me after 1 year and wanted to have prosthesis be put in. I used an octopus cup. I used a ZMR, and I brought down the greater trochanter, and the patient had a very good function of prosthesis. This is a primary hip, 10 years, now infected, replaced by a cementless hip and solution stem with closed irrigation for 1 week. 6 years ago, still doing well until 70. This shows you the prosthesis. It was applied, and patient is really doing well. I was able to put the cup at the true hip center. This is a 76-year-old who presented with the draining abscess and grew yeast and pseudomonas. This patient, I did not have a success. The patient continued to drain, and I kept on putting him on amphotericin and antibiotics because he was a poor risk patient and I could not operate any further. So we had the infecting organisms, 25% were gram-positive organisms and consisted of Staph aureus and epididymis. 12.5% were Pseudomonas, 12.5% was Pseudomonas and yeast, and 50% revealed no growth. All our patients were put on IV antibiotics for an average of 2 weeks, followed by oral antibiotics for not less than 6 weeks. The results: 7 cases have no recurrence from 8 months to 9 years follow-up. 87% good to excellent results. 1 recurrence, intermittent collections of pus over the trochanteric area. The organism was Pseudomonas and yeast, controlled by antibiotics. The patient refused further surgery. One should identify the presence of an infection. Should do a proper history and proper physical exam. Do a white blood cell count, ESR, and CRP. Bone scans, technetium, indium 111. Monoclonal or polyclonal, 80 to 98%. So you get in the knee, the same thing, 2-stage exchange, 1-stage exchange. Always obtain pus for culture. You have to mix your cement. We use often vancomycin, gentamicin, amphotericin if we have suspicion of fungus. Also, at times we use tobramycin. And finally, how we do it. And if we're not successful, we either excise the prosthesis, we do an excisional arthroplasty, or we fuse the knee. And finally, I say thank you. Thank you very much. Was I clear? Was I clear?
Dr. Jone?
Any questions?
Dr. Jone?
Hey, Abisma.
Thank you very much for this concentrated lecture about periprosthetic infection. Actually, the infection is the enemy for all orthopedic doctors, especially arthroplasty cases. But I want to ask, in preoperative preparation for the patient, how we can follow the best measures, because some surgeons quickly can do the arthroplasty without full preparation, especially in cases of primary focus of infection.
Khalid, the best way, let me tell you. First of all, when you get the patient, you should take a proper history and do a proper physical exam. Sure. After that, you should do a complete workup on the patient. If he has poor comorbidities, if he is a diabetic and has an HA1C, which is higher than 7.5, you should control the blood sugar and bring it down, and bring down the HA1C. Bring it down. That's number one. Number two, you have to, first of all, look at the patient, do blood tests. One important test is the albumin determination. If the albumin is low, meaning less than 3.5 and quite low, then it worries me. I wouldn't do the surgery. If the white blood cell count is less than 1,500, he's a poor risk patient. I wouldn't like to do it. If the patient is even what they say in the dental, if he's doing his teeth, I tell him, do your teeth and then come to me after 3 months once you're finished. I will not do it immediately. Then what I do, I make sure that the skin in the area is clean. I make sure that there's no lesions in any part of the body. And I tell my patient to have a bath wash every day for 3 days before the surgery. يقعد بالمختص يغسل حاله and everything. And if the patient is a male, I ask him to shave 1 week ahead of time, not immediately. These are all points. Another point, this is from the side of the patient. This is very important from the side of the patient. Be careful. Look at everything. Look at his comorbidities. Now, you have to make sure that the operating room is clean. You have to make sure that your assistants are not carriers of infection. You should make sure of the protective gowns that you wear. Wear double gloves, preferably. Each glove is of a different color. Okay, so this is very important. Another point that we realized that our infection rate dropped by the short period of time that we kept the patient in the hospital. Yani, during total hips, there were some we discharged the next day at our institution. At most, we keep them 2 days in the hospital. We avoid using drains. Why? Because, first of all, patients emptying the hemovacs. You don't know whether the nurse knows how to empty it. You don't know whether your resident is honest and does this himself. We don't like using drains in our patients. We work in a bloodless field and we close in a bloodless field. We make sure that hemostasis is well controlled. In the knee, if we use a tourniquet, we always deflate the tourniquet before closing the wound. We coagulate or tie all the major bleeders, make sure there's no bleeding. Mind you, the knee is an empty room where blood can deposit in it and predispose the patient to an infection. Mind you, if you notice, I said the rate of infection in the knee is 2%, while in the hip it's lower, less, and around half the amount. You've got the point. So these are all points you have to take care. If you want to do total hips, you have to be the leader in the operating. You should not allow anyone in your room when you're operating. That's number one. You should be a clean and a good surgeon. Don't make multiple incisions. Make one single incision directly to the region where you want. What I've realized, I've taught so many residents. There are some who are good and some who are bad. The ones who are bad, they make multiple stab wounds. They're not sure where they're making the incision. The more you make stab wounds, the higher the risk of infection. Go directly to the area. Avoid going or hitting the bush, doing this or doing that, because you're not sure of what you're doing. You try to be sure in time. The operation, the short, it should not take more than 1 hour to do a total hip and three quarters of an hour to do a total knee. So this is something you should know. Okay?
Okay, thank you, Prof. Everything is clear, and this is the factor that we follow them. There is a point that some patients, we follow them by the measures of ESR, CRP, and the White differential count. We notice that it is high, and we can give the patient, or we can search the focus of infection, like upper respiratory or UTI. And in many weeks, it's still or remain high. In these cases, we did for them cultures, and we tried. So, so we noticed in the last 3 years there is a decreased in the rate of infection in our centers, alhamdulillah, because we follow them, beside the factors that you told about.
Like Khalid, also the operating nurses and the nurses in the operating room handling the instruments are very important. The more they develop experience, the less the infection. So you have to realize this. The more experience, the less. I work in two types of hospitals. One, the university hospital, and one, we call them the periphery hospitals. They are free hospitals. They're cheaper. It costs the patient to have an operation much less than having it at the university. I'll tell you, when I leave the operating room in one of these hospitals after doing a total, I cannot speak anymore. Why? Because I yell all the time. They have no experience. Nurses go in and out of the operating room. They hit their gowns on the table. They have no experience of throwing instruments in a water pan, etc. But you have to teach them all. You have to teach your residents. Be honest. Manu, I was criticized on this. Anna, I don't believe in beards. Why don't I believe? Because if a hair comes down into the wound, this beard, you can have an infection. I think, in general, the surgeon should be clean. The surgeon should, really believe me, should, before coming to the operating room, he should have a nice shower at home and use Sidal soap. Sidal soap. And then he comes, especially if he sweats. If he sweats, this is a problem. But then shaving, don't forget to shave your patient 1 week before the coming to the operation. Why? Because you have sweat glands. Sweat glands contain microbes. If you shave them in the operating room and you provoke these organisms to come out on the skin, this is another point. Another point, how they scrub is very important. They should scrub in the center and then move out to the periphery. أنا بقشع residents بيكونوا scrubbing with other surgeons and they come to scrub for me. They start to scrub at the periphery and then go into the center. يا جماعة الوساخة من برا بترجع بتفوتهم لجوا. These are points you have to put on a list or on a paper and pencil and study them, Khalid. Okay?
Okay. Thank you too much, Prof. والكل يسلموا عليك. وبيسمع. شكرا لك.
في حدا من الجماعة بيحبوا يسألوا؟ أنا حاضر. أنا حاضر، ماني تعبان، بقدر أقعد أحكي لبكرة على بكرة.
Dr. Muhammad, he is now 40-year trainer. He asked about the use of cautery, the overuse of cautery. Can it affect or increase the rate of infection?
You see, cautery, what does it do? Cautery depends if you use it like what I stressed before. مش يعني تفوت وتظهر. Not only you come in and out and in and out. لا, يعني when you're cutting with cautery, it's got to be straightforward. مش يعني ترجع تقص من تاني جاي using cautery. You know, cautery is known to cause necrosis. Now, if you use it a little, ما في harm. But if you use it the proper way, if you don't use it the proper way, لا. فهمت شو؟
And for necessary dissection, just.
Hey. And for cauterizing small vessels.
Just, yeah. Not over or, yeah.
Look,
Thank
I'll
you,
tell
Prof.
you what. I'll tell you what.
Yeah.
I don't think it's a matter of cautery or what. It depends on the surgeon should be
Patient.
quick and work according to the proper anatomy. 2, you have to operate clean, to the point, do the essential, and get out. Finish.
Yeah.
Don't rattle around. أنا 100
Yes.
مرة بضرب إيدين الشيف ريزيدنتس لأن أنا بخليهم يعملوا تقريبا كل البروسيسز. If they do wrong بضربهم على إيدهم. You have to pay attention to this.
Yeah, thank you very much. Okay. شكرا يا دكتور جون و have a nice day.
يا أهلا بقشعك نهار الجمعة الجاية بالأردن.
الخميس إن شاء الله.
إيه بقشعك و you will be attending بإذن الله the Yemeni charts. إن شاء الله يكونوا بس عاملين sufficient training. The only thing I cannot help in if they have insufficient training.
No, the
you feel
training
that
is,
your residents have had sufficient training?
Yeah, they have sufficient training. And you know, Dr. June, at December 2022, we do for them examination. There was about 28 trainees.
Very good.
Yeah, the success was the half, about 14. So we do examination every year from the second, third, and fourth year. Yeah, so they are good training. Really, they have sufficient training, but during filling the logbook, and this is the first time, and they didn't know how to fill this
what
courses.
I want you to say when you arrive, you tell the group, you know, I'm only head of the committee, but I'll tell you tell the committee, I'm an old surgeon. I have operated so long, and I need time to learn on how to fill this logbook. And I want you to tell them something. I'm coming all the way from Yemen to learn what is best and how to fill this logbook.
And how we can improve.
هيدي بدك تقولها وهيدي this is what I'm fighting for. I'm fighting not only for you to come. I'm fighting for any coordinator from any of the Arab countries, even if they're excellent, to come and meet with us.
And we can learn how, what they want to, what is the steps to improve. This is good for us, but really the trainees of they are good in the training in the years, and every year we do examination, and who are not sufficient, we let him to stay in the same area.
Look at what you do. You should call this the Yemeni in-training examination.
Yeah,
Yemeni
really, every
in-training examination. But you know what I do? I do it twice a year. I think, like it, يلي عم يسمعني منيح. I could be the father of every one of you. I'll tell you, you are children. You are my children. If nobody stimulates you to read, you won't read. If you know that is a nice film on TV and you have an examination the next day, believe me, many of you will choose to watch the nice film. عم تسمعني خالد؟
اسمعك والشباب عم يسمعوك.
بدي اياهم يسمعوني. اكره شيء عندي بالفحص اسال اسئله واحد يصفن علي ما بيعرف شيء. This I would not accept. This I cannot accept. And that's what I'm trying to tell you. Okay?
Thank you very much. Thank you, Dr. Jone. Yeah, thank you too much. And all the colleagues, thank you too much.
هلا بدي
Okay.
اقول له next time I'm speaking about the arthritis and related topics. فهمت شو؟ This is
Yeah.
very important. And the next talk will be on the collagen diseases, like other diseases, which you know. I will discuss them later. Okay?
Yeah. Okay.
بدي ليك عم بقول لك الدغري انا عم بعجل لقد ما فيي. I included so many topics in today. The reason why بدي جرب خلص لهم the major part. بس هلا traumatology انا بنصحهم يبلشوا يراجعوا traumatology. Trauma نخليها للاخر because they are dealing with it every day. سمعت خالد؟
Yeah, daily. Yeah.
This I would like to لأن ما معنا وقت للفحص يلي جاي. Okay?
أيوه. Okay.
يلا.
Thank you
Good
too much.
night and
Good
have a
night.
good day.
Thank you very much. To you.